It's true that the results that I'll present at the meeting tomorrow will be exciting and will change the practice in CLL, chronic lymphocytic leukemia, and small lymphocytic lymphoma, which is the same disease in nodes. CLL is the most common hematological malignancy, or certainly the most common leukemia that we see in the Western world. It is a disease predominantly of the elderly. The median age diagnosis is 72, although we see patients in younger adults who have the disease. There are subgroups of patients, and referring to the personalised medicine, there are subgroups of patients who have very poor outcomes with conventional therapy. For example, patients with deletion of chromosome 17p, which is the loss of a tumour of p53 oncogene, leads to lack of response to chemoimmunotherapy and very poor survivals for patients both initially and at further outcome. And most patients will respond initially to therapy but eventually relapse and become resistant to therapy, with the majority dying of either the disease or the effects of our chemotherapies that we use. Over the last few years, it's been clear that the biology of CLL is more complex, that CLL cells require stimulation through receptors on the surface, and I'll talk about that in a moment. And this has led to the development of a number of therapies. The principal one, certainly that is leading the way, is Ibrutinib, which is an inhibitor of Bruton's tyrosine kinase, one of the important molecules that allow CLL cells to proliferate and to survive. So the RESONATE trial was the first randomized phase 3 trial comparing Ibrutinib as a single agent with an approved therapy, ofatumumab, in relapsed and refractory CLL. So patients rarely where conventional chemotherapy is not effective. So as I mentioned earlier, we understand more about the biology of CLL. So we have conventionally thought of CLL as a mature tumour that just accumulates until a patient then runs into problems and we have chemotherapy. But what's quite clear now is that this is the CLL cells we see in the peripheral blood, that they circulate into the lymph nodes and into the bone marrow. And this disease, we see patients with very large lymph nodes, big spleens, and bone marrow replacement. The cells then get a stimulation while in the tissue compartment to grow, so they start proliferating and grow very rapidly. And then they come back out of the tissue compartment into the peripheral blood, where they quiesce and switch themselves off to some extent. And then they circulate back into the tissue. So you get this circulation of cells through the tissue that is required to keep the cells alive and to make the disease proliferate. And what we know now is that this proliferation is driven in a mirrored way to normal B-cell biology, and the key player, or one of the key players, is the B-cell receptor. So this is these B-cells are designed to make antibodies as a principal part of our immune response. And what happens with CLL cells is that there's stimulation through the B-cell receptor, which leads to signaling into the cell, which leads to proliferation, homing, redistribution, differentiation. And this molecule, Bruton's tyrosine kinase, which was first recognized in young boys that couldn't make antibodies at all, and it was deleted in the X-linked gamma globulinemia, is key to the passage of the signal from the surface to make the cell do what it should do. So it's clearly a very specific molecule that can be targeted in B-cell malignancy. So Ibrutinib is a irreversible inhibitor of BTK. It is an orally available small molecule. It therefore stops the stimulation of CLL cells and indolent lymphoma cells. It stops the homing of cells into the tissue microenvironment, and in the phase 1, phase 2 trials showed dramatic responses in terms of lymph nodes and spleens, with an increase initially in the level of leukemia in the blood, which has no deleterious effects, and then over the next few months a continuing reduction as the proliferation stops. So the phase 1, phase 2 data for Ibrutinib over the last couple of years has been extremely impressive in a very difficult group of patients. So the RESONATE trial is, as I mentioned earlier, the first randomized phase 3 trial in which patients were 391 patients were randomized. These were patients who had failed prior therapy or were unsuitable for chemoimmunotherapy because of genetic abnormalities such as 17p deletion, or were unfit to have repeat rounds of chemotherapy. 391 patients were randomized, 195 to Ibrutinib, 196 to ofatumumab. Ofatumumab is an approved agent, single agent monoclonal antibody in CLL that has efficacy in this group of patients. At the outset of the trial, there was no crossover between the arms was allowed, and this is important, but the Independent Review Committee, on reviewing the data blinded to the investigators at a point in follow-up, said that we should cross over patients when they progress from the ofatumumab arm, as you'll see, because of the responses that were being seen to Ibrutinib. So the first interim analysis was performed with a median time of only 9 months on therapy, and the trial was stopped at that point, and the data I'll show you is from that analysis. So the primary endpoint of the trial was, as is standard for CLL trials, was progression-free survival. This was defined by an independent review committee, so it was not dependent on investigators' assessment. And this is the primary endpoint, showing a very significant difference between the Ibrutinib arm, shown in the solid line, and the ofatumumab arm, where virtually all the patients have progressed by 12 months after initiation of therapy after randomization. This is, as I mentioned to you, an IRC-driven and in many patients CT-driven progression, so clear, independently shown progression. The hazard ratios for PFS were very impressive, so 0.21, so there's a much higher chance of remaining progression-free in the Ibrutinib arm, as you can see. It's highly significant statistically, even at an early follow-up point, although the patients continue. The surprising result, I think, was that we saw an advantage in overall survival. So many of these patients crossed over relatively early in the treatment, so between 4 and 6 months into treatment, patients crossed over from the ofatumumab arm to the Ibrutinib arm, and what we saw was there was a separation of the two curves in terms of overall survival, but then when patients crossed over, which is happening around this stage, there's a plateauing of the ofatumumab arm. So this confounds the assessment of overall survival, but I think in this group of patients, it's the only randomized trial that shows a significant overall survival. And in our previous experience with all other therapies, this survival curve would be down at 50%, certainly sometime to 12 or 18 months after with a difficult group of patients. So it's an impressive result with a very impressive hazard ratio. So I think the conclusion of the trial is the primary endpoint is what is met to a high level of statistical analysis, and overall survival is also improved. So in conclusion, Ibrutinib has a significant effect as a monotherapy and is clearly better than ofatumumab, the current standard of care for patients with relapsed refractory disease who can't be treated with chemotherapy. It has a major impact on progression-free overall survival and overall response rate, including in all subgroups, including 17p deleted and VH unmutated, so the poor risk groups of patients. Despite a crossover, the overall survival shows a significant improvement. I've not shown you the toxicity data, but the drug is well tolerated. We see some minor diarrhea in the early stage of treatment, which is very well tolerated. It doesn't require the cessation of therapy. And so most patients remain on treatment on the Ibrutinib arm to this current point, and we will obviously get further updates to this trial as we move forward. And there's no doubt that this agent will have a major impact on our treatment of CLL, both in the refractory setting and now we're studying it in earlier stages of the disease. Thank you.
Thank you very much, Dr. Hillmen, for presenting these exciting data, in particular the improvement of overall survival. That's really groundbreaking. Any questions from the audience? Dr. Hillmen, please. If I may kick off, I mean, do you expect that with these new, smart, effective molecules, you can cure the disease with monotherapy?
I think, Anton, with monotherapy, it's unlikely we'll cure patients. We have data now going out towards 4 years in relapsed refractory disease, and we're seeing very good responses still in some patients. In the very limited treatment-naive data, we're seeing even better responses with very few patients progressing, but I don't think we're getting to cure. I think the excitement will be, as we'll hear in subsequent presentations, we have multiple different molecules which target the biology of B-cell malignancies, and the combination of these agents may well move us towards cure of the disease.
Questions, please. I saw you there. Yeah.
How does this compare to the other
To,
The other anti-CD20s? Is an ofatumumab
yeah, so the ibrutinib is the results of the control arm in this trial are similar to the rituximab therapy and previous experience with ofatumumab, but of course ibrutinib is the drug that shows the advantage, and I guess we have idelalisib, which is the comparator for that for ibrutinib, and both that's used in combination with CD20 antibody, whereas this is used as a single agent. I think the responses are still fairly early in the follow-up of the trial, are very impressive for ibrutinib. I think the control arm is, certainly in terms of progression-free survival, doing what we would expect with other CD20 antibodies.
Further questions? Yes, please. Can we have some more light, please?
So, Walter Alexander, Cancer Watch.
That's impossible. Okay, that's a clear answer.
What's the approval status of this drug in Europe and the US?
So I believe that in the US it's been approved in mantle cell and in CLL now. In the Europe it's going through the approval process, and I think the investigators, and I don't speak for the company, expect it to be approved later on this year for, we don't know what, but I presume for relapsed refractory CLL, and that's certainly been submitted. This data will, of course, will be submitted as well, which will, I'm sure, lead to an approval as a single agent in Europe.